Welcome to episode 9. I'm your host, Dr. Carl Bernstein with Triangle Dentistry Talk. Today we have a special podcast. We're here with Dr. Miller from Miller Concierge TMJ Physical Therapy. How are you today?
I'm doing well. Thank you so much for having me, Dr. Bernstein.
And this is a wonderful podcast that I think that we're going to have today because so many people have TMJ issues, which is what we're going to be kind of focusing on, obviously with the office name. Hopefully you picked that up. But today we're going to be focusing really on TMJ, TMD issues. And I think a lot of people have these issues and are not even aware that this is where it could be coming from. So let's kind of get a little knowledge and a little information about who Dr. Miller is. So tell us just a little bit about yourself.
All right. So I'm Dr. Leigh Miller. I am a physical therapist by trade. And so about 4 years ago, I decided to open up a private practice that completely focuses on TMJD treatment. And one of my interests in the niche is because my family is in dentistry. So my dad is a dentist, recently retired, and my brother is a prosthodontist in the Durham area. My sister-in-law is an orthodontist in the Raleigh area. And so it's just sort of an arena that I grew up in. Although I didn't become a dentist, I still comically ended up in the mouth one way or the other.
I know you still found your way there.
I found my way there.
Save maybe a little bit of schooling and a little bit of annoyance there too, as well.
Maybe so, but the niche that is TMJPT is so small in the physical therapy world. To be honest, in order to get board certified in it, which is what I am, there are only about 40 of us nationwide.
Wow.
So there's just not that many of us. There's a lot of steps that are required after graduation that make it so you can become board certified in this topic.
And I think that's one thing that we're really lucky to have in this area, the triangle, if we want to just call it that, Raleigh, Durham, Cary, and the area surrounding is we have so many specialist fields that are not in every city and not in every area. And so we're lucky to be able to have someone like you that can treat these patients, because it's definitely difficult and it's hard to get really good care. And we're lucky to have you.
Thank you. Thank you very much. And, that's part of what led me to this. So in addition to, yes, growing up in a dental family, I actually was, for all of the dental gurus that are listening, I was born without my lateral incisors. And so it created a orthodontic, I'm going to call nightmare for me, just because I was in braces for about 7 years.
I would agree.
And this was in the 90s, right? It was pre-implant popularity of implants. And so what ended up happening is we moved everything forward and we have crowned my front 6 teeth. And so in the process, I started noticing that I was experiencing a lot of jaw pain just throughout all of the work that I've had done. And I couldn't quite figure out what was going to alleviate it. My dad being a dentist, I was on muscle relaxers. I was given a couple of exercises like stretches. But at the end of the day, it was something that I chronically lived with for a long time. Mm-hmm. And so when I went to physical therapy school, I thought, you know what, there's a lot here that is just not addressed in society. Dentists focus on occlusion, dentists focus whatever specialty you are, right? It's the teeth or the nerve of the tooth or the gums, right? Or the placement and positioning of those teeth. But is there anyone that's actually helping with the muscles? Because the jaw itself, the TMJ, it's always a really probably not so funny joke. People say, I have TMJ. And I'll say, yes. Oh, I know. We all do.
I know. I always laugh at that too, because even in my head, when I'm explaining to people, I'll say, TMJ, TMD, temporomandibular disorder. We all have hopefully we all have
we all have 2 TMJs. That's exactly right. And so, I started diving into that. Like, how does the jaw fit in with occlusion? because they're not the same thing, right? So, they work together. They work hopefully in harmony. Many times, the reason we have symptoms is because there is some asynchronicity between our bite and our jaw and those muscles. But that's sort of how I started to dive into this. Is I'm a big person that believes in conservative treatment. I don't want to jump the gun here, but I'll just go
Right.
ahead and say it. I'm not the biggest fan of Botox. And one of the reasons is not because I think it doesn't work. It's plain and simple. If you want a muscle to relax, if you need a muscle to calm down from an overly tight environment, you need it to work. And when you do Botox, what you're doing is you're creating a flaccid environment. You're creating paralysis to some of those fibers within the muscle, mainly the masseter muscle. Um, and so it creates this imbalance and it gives a false positive that alleviation is because we're helping the situation. When in all reality, it is just a metaphorical way to kick the can down the road.
And
Um,
and I know we'll get a little bit more into that, and it's we're excited to get to this information. I am
yeah,
too, because just like how you said, I grew up and my mom's a dentist,
yeah.
and she always thought that I had TMJ, and I would complain of frequent headaches. I would
Hmm.
complain of issues, and my bite, like you said, sometimes it's not associated with the bite, and we looked at, went to other
Hmm.
orthodontists, and she sent my models to other people, and my
Yeah.
bite was good, everything was hitting, and still having TMD issues and
Hmm.
things like that. But one thing that I found out as well is that it wasn't necessarily my joint. I also had a brain tumor that I that I
Okay,
had
well, that
paid
would
for.
also,
So,
oh my goodness.
and that can also cause
Yeah,
some other issues.
that
But
will also
uh,
cause other issues. Yes.
and that's
Um,
the thing as well, is that things can all, I think the nice thing of sometimes hearing that as well is it can also be, everything could be good and it's something else, and so that's always things we got to have a big team as well to figure out that it's not something more serious as well.
and to that point, absolutely. To that point, I feel as though, heretofore, um, the concept of a multidisciplinary approach was, in my opinion, something you talked about in school.
Mhm.
You'd maybe do a project on it, like, ooh, how can we all interact together? But then everybody gets out in their field. You go 9 to 5 or whatever your times are, and then that's kind of it. We become very pigeonholed, very myopic on our specific area that we specialize in. And the problem is that with TMJD, um, it cannot be. It's impossible. You cannot treat TMJD if you're only looking at the muscles. You
Mhm.
cannot treat TMJD if you're only looking at the teeth and the occlusion. There's also a psychological component to it. So it is physically impossible to correct as much as possible you can the TMJD symptoms if you're only looking at it from one profession.
Exactly. And so let's take a quick step back and let's get a little bit more information about kind of your
Yeah,
offices, which is again, Miller Concierge, TMJ Physical Therapy. Where are you
sure.
guys located?
So we are located inside of dental offices. So with that being said, that is just the most optimal space for us to interact with the profession. Our first office is in Durham. It is at 55 and 54, if people are familiar with that area, what used to be Mark Hunt's dental practice or the Triangle Dental Institute. We are located inside of there. I have another office that is in Raleigh off of Glenwood Avenue and Lake Boone Trail, but not on the hospital side, on the Glenwood side. Dr. Mary Morgan Kaiser is on the first floor, and we are on the second floor. And we just opened up 2 or 3 weeks ago our Fuquay location, which is in Dr. Kristen Langworthy's office, which is off of Judge Street in Fuquay.
Awesome. Well, that's good. So we are definitely around the area.
Yes,
A lot of opportunity for people to get in and be able to correct some of their issues. And
absolutely.
let's I guess quickly, what is differentiating between you guys and just a regular physical therapist? Because I
Great
think a lot of
question.
people will, kind of like every profession, we're all
Mhm.
dentists.
Oh yeah.
We're doctors. You're a doctor. You can help me.
Oh yeah.
You're all physical therapists,
Oh
and so
yeah.
everyone, there's a big difference. So
There's huge.
go ahead and explain that.
Okay, so that's very true. You come out of graduate school, whatever the profession is, and it's like go forth and
Yeah.
treat, and go forth and treat the entire body if you're a physical therapist. And in all reality, as physical therapists become more so veterans in the field, they end up niching down on an area of the body that they really enjoy working on. And that is because when you treat the entire body, it's just impossible to become a specialist and know all that there is to know as research continues to come out on a daily basis. And so, what differentiates us from other PT practices that may say, hey, yeah, we treat TMJD? Um, what we do is not only so having that board certification, we don't just dry needle you. We don't just go in and do some easy range of motion. We look at your case as a complete and total package. And we actually look at it sort of like a puzzle. And with that being said, we are factoring in that relationship with the dentist. So not only do we need to know what type of occlusion do you have, right? We need to know what your dental history is. Have you had braces? How many times have you had braces? These are all things that we have become knowledgeable about. And then in addition, we will then go and do a series of manual therapy and modality treatments. And what that means is, a grade 4 medical laser treatment. We do dry needling, we do manual therapy, but we also do a lot of just intraoral work and exercise. And each thing builds upon itself. All right. And then at the very end, what we do is we then send that particular patient back to their referring provider, and we send a prescription with them for the type of oral splint that we think is necessary for them moving forward. So we have a lot of interaction in the dental world, in addition to just being board certified in it. And that is very different from any other PT office.
Well, that's great. And I think probably the big question that you maybe hear with everyone, every visit that you go to, no matter where, is how do appointments normally go? So if I was a new patient coming in, what should I be expecting?
Yeah. So
And you can go as in depth, or you can go,
yeah.
we'll obviously touch on more things as well, but go ahead.
Sure. So your dentist, about 98% of our patients are referred by a dental provider. May that be an oral surgeon, may that be an endodontist, prosthodontist, periodontist, orthodontist, or just a GD, a general dentist. And that's because there isn't one specific area that's going to see TMJD pop up. Most of the time, you may have something dormant going on in your muscles and in that joint that only a long open mouth procedure exacerbates, right? And what does a long open mouth procedure mean? Anything greater than 8 minutes can create an inflammatory response in the bilateral TMJs that then, if something is asleep and dormant, right, can then wake up and make some noise, right? So when you come in, if you have a referral from a practitioner, we'll take a look at that referral. We'll take a look at any images that you have, if images are sent over. We love images because it gives us a little bit more of an understanding of what's happening within the condyle, how the relationship between the condyle and the fossa, all right, and then that disc. Also, if you are pre or post-op, there is a procedure and a certain set of steps that we follow to get that patient functional. But back to the basic question, patient comes in, we take a look at their history, anything that the dentist has sent over that could be pertinent into what's going on with them. We do tap a little bit into the psychological aspect of who they are, right? Are they in a really stressed environment or not? And no, we're not going to cure that, but part of it is just making the patient aware, number one. Number two, a lot of times when we're stressed, our posture changes. And so a posture is a big part of what we do. And so it's, again, education and awareness for that patient. We then have the patient lay down on the table, And we take a look at their bite. We take a look at what I call the mandibular gait. So we have them open and close with their tongue up, tongue down. We're looking at different movement patterns, different sounds, right? So we will do some ultrasound to the joints bilaterally to see, am I listening for crepitus, or do I hear any sort of potential disc displacement, that pop and that click? We take obviously range of motion. And then I take a look at your cervical spine. A lot of people don't realize that compression of your C1, C2, we have 7 cervical vertebrae, right? Compression of C1, C2 can actually change the position of the mandible, right? And it can push it back posterior and slightly superior. So things like this is what we're looking for. It's extremely comprehensive. And then we send that report to the referring practitioner. So everybody's on the same page. And that report is about a 7-page report. I know it's kind of long. It's just very comprehensive and inclusive of everything that's going on. From there, then we talk to the patient about what we think is going on, the diagnosis, and how we think we can help them.
And how is there a certain number of appointments where if someone were to say, do I need to come for 4 appointments, 5 appointments, or is it really, I mean, I know everything is always patient centric and dependent on what their needs are, but is there kind of an average that you normally would see?
Yeah. So there is an average. When it comes to tissue healing time, and this is just something that every physical therapist looks at, but when it comes to tissue healing time, when we're talking intraoral, it's a minimum of about 8 weeks from start to when we can actually see some change in that what we call mandibular gait, the tonicity, if you will, of those muscles, so the tightness of those muscles. So we will do packages, and we will tell the patient, okay, it's going to be a minimum of 8 sessions, period. You cannot, it is physically impossible to treat TMJD in any platform with a one and done session. What that does is symptom treatment. And I am not a big fan of symptom treatment because you're always a dog chasing its tail. Right. And it's just that's sort of what Botox does at the end of the day. You're always going to need it. It doesn't cure anything. Right. It's not preventative other than to get them out of pain. So what we do is we say, okay, it's going to be somewhere between 8 to 12 weeks, once a week. All right. And in between that time, I'm going to give you homework. And I know nobody loves homework. We try to keep it minimal, so that it doesn't interfere with your daily activities. But it is basically the homework correlates with where you are that week. So it's going to change. It's not the same stuff over and over. It's not just posture. It's also intraoral. There are devices that we use called hyperboloids. They're silicone-based devices, and we use them to bite down in different capacities, if you will, to retrain that bite once we get those muscles to an acceptable place.
Well, I mean, that's really good information because I wouldn't have fully known, it's definitely, it's something that as dentists, we obviously are taught and are aware of, but we don't, I think one thing and I think many would say in dental school, we learn about TMJ, we learn about TMD. We don't really learn about full correction and we learn about looking at the bite. We learn about that, but not as much of the musculature and surrounding structures, which I think as we are aware of and learning more with you as well, that it's really important. So I think, having someone and be able to refer to,
Absolutely.
which is kind of leads to the next question is, as an orthodontist, me specifically, again, and Carrie, but it's, when is a good time that we should refer? What kind of symptoms are we looking for? Obviously we can listen to the patient and hear what they have to say, but what are things that we may look for as well and say, did you know you had this and this could be causing some issues? And they're like, no, I didn't, wasn't even a thought in my head. I didn't know I had any issues. So, go ahead and give us a little bit of information on that.
Yeah, sure. So, a lot of times the patient may or may not know that they're clenching, grinding, or bruxing. It is an activity that comes from the central nervous system, and it is in our subconscious. So it is not something that we are always aware of. Research has shown that you actually brux more during the day than you do at night, even though nocturnal bruxism is very much an issue. So, it's a myriad of things that can be told and or observed by the practitioner. If the patient comes in just plain and simple and tells you that they have jaw pain, tells you that they have ear pain, they've been to the ENT, maybe they'll say this. We get this a lot. I don't know if they would say it to you, but they've been to the ENT and nothing's wrong.
Yeah, we'll get like I've been to ENT,
Oh, yeah.
I have some tinnitus or ringing in the
Yes.
ear, and they say nothing's wrong. And some have I said go to an orthodontist, so then we do get
Well,
that.
I like to, Carl, I like to say that, and I say this because I am a physical therapist. In the orthopedic world, it is just sort of a joke that physical therapy is the garbage disposal, right? If the patient cannot be operated on, send them to PT and we can fix them. And I say in the dental world, if the patient has jaw pain and you don't know what to do, send them to orthodontic care.
Orthodontist is always kind of or send them to ortho. They'll
send them to ortho. And so I want to make note before I answer the question about more symptoms. Orthodontics, and I get this question a lot. Does bad orthodontia, quote unquote, cause TMJD? No, it does not. What it can do is it can exacerbate muscles that are already in a non-optimal position, right? But it doesn't just create it. Many times there's underlying issues such as hypermobility in the bilateral joints, right? Which can create disc issues, all right, and instability within the muscles themselves. But it's not because a dentistry itself or the treatment that a patient received within the dental field caused it. Does that make sense?
Yes, that's good information to have.
But so kind of back to it, a patient that comes in and says, hey, I've got pain in the ear, or I don't have pain in my ear, but it just feels really full, like swimmer's ear or something. I feel like I can hear myself talk. I have tinnitus. I have a headache that runs from the back of my head to the front in sort of a ram's horn fashion, right? A little arc-like motion.
I've noticed a lot of people kind of like on the top of their head where they're like, what's up there?
Oh, yeah. It's your hair, what's going on? Pain into the temples themselves, right? So the temporalis, any sort of mechanical symptoms, popping, clicking, locking. I say to patients, have you ever had a lockjaw before? And some will say, actually, yeah, I did, but it was a long time ago. Immediately I think, okay, that's not just trivial information. That's actually really good information to tell me the status of where the joint is. We try to correct ourselves. Our body tries to protect itself. Our mouth is used over 3,000 times a day, right? Eating, chewing, talking, singing, swallowing, breathing, kissing. Okay, so, and it also has that psychological component to it, right? So there's never really a time that we can just metaphorically go home and prop our jaw up, like you can with an ankle that may be in pain or a back that's in pain. And so patients will sometimes live with discomfort and normalize it. And at the end of the day, there's no reason a patient should normalize discomfort.
Right. When you would say, popping, clicking, because a lot of people have popping, clicking, and I would say if you probably ask 10 people, I feel like 8 would say, yep, I have had popping, clicking, or he does it all the time, and most people don't have any symptoms or any issues and maybe never will. But what are your thoughts with, if someone has popping, clicking, they say, I don't have any issues. What should they do?
So I do not believe that every patient that pops and clicks needs TMJ PT. There is, all that does is that tells you, okay, the disc itself, when the disc is inside of the TMJ. So to give a little bit of background, you have a ball and socket joint, right? The ball is your condyle. It's attached to the mandible. The socket is the temporal fossa, and it fits together. Okay, just like your shoulder joint would fit together or your hip joint would fit together. You have a disc, and it's sort of a metaphorical water balloon, if you will. It's fluid filled. The disc
Mm-hmm.
itself is avascular, right? So if this water balloon sort of moves in and around the joint, just like our meniscus in our knee or a labrum in our shoulder, if it moves around, we're not going to feel it. The only thing that we can feel is the material behind the disc, okay, that attaches to the cranium or the temporal bone. So that is vascularized. We call that retrodiscal tissue. People who get irritation to the retrodiscal tissue are going to have quick zaps of pain.
Mm-hmm.
And so that is something also that a patient can report. But if a patient has popping and clicking and there's not really pain associated with it or limitation associated with it, it could just mean that that disc is moving anterior in front of that condyle, every time you open and close. So then the next question would be to the dentist, okay, well, did you do a quick assessment of their medial or lateral pterygoids? And it takes maybe 2 minutes,
Mm-hmm.
right? Just to go in, palpate the medial and the lateral pterygoids. And if those are pretty upset, if the patient starts to wiggle their feet, right? If it lights the patient up, then that patient most likely needs a referral because they are at risk for a permanent disc displacement without reduction or return. If it doesn't create pain for that particular patient, I think that they should just be aware of it,
Mm-hmm.
right? And to kind of monitor their symptoms, if
Well,
that
that's
makes
good to
sense.
know. And I think this kind of comes into a great, next question,
Mhm.
especially for me in the sense being an orthodontist again is, what is the best order of events? Let's say,
Mhm.
you have someone maybe with some symptoms, is it good to have orthodontic and physical therapy simultaneously, or is it
Good
good to
question.
have physical therapy first or orthodontic, treatment first? I guess,
Mhm.
maybe it depends like every situation
Mhm.
and everything in life, but go ahead,
You know that I'm going
let
to
us
say
know.
that it depends.
Yeah.
But to kind of bring it to an elementary response, right? It can be all of the above. So
Hmm.
if you have a patient that comes in and they are pre braces, right? Now I don't mean an adolescent. I mean maybe like a 20-year-old that needs braces, whether for the first time or the third time, or a 30-year-old that may need braces. Physical therapy prior to would be most optimal for them because that would allow the muscles to not fight the movement of the teeth, right? Because tight muscles shorten up. And
Hmm.
when they shorten up, they pull. And they're not going to pull on the teeth per se, but they are going to pull on the mandible where the teeth sit. And so this creates sort of a where's my bite situation, right? It really creates a situation where they try to find MIP. You're looking for MIP, right, when you do orthodontia, but they may be sort of trying to find it all the time because you get it with the braces, take the braces off, and now there's a shift. And a lot of that could be because maybe they're clenching more, right? Um, because of some issue going on within the joint or the muscles. If you have a patient who's in a lot of pain and they're already in braces, they just got rubber bands and
Hmm.
they are just saying it's really, really tight and very uncomfortable. Honestly, that could be a patient that would benefit as well because you have them come in and what we do is we take the rubber bands off and we actually work those muscles, just like when you go to the gym. We work those muscles in different ways so that they don't fight the rubber bands, right? You don't want somebody to be in rubber bands and never move their mouth
Right.
because they're in so much pain, or not wear the rubber bands because they're in so much pain, but they put them in when they go see you, and that kind of thing. So it depends. I encourage patients that are not necessarily adolescents, and I say that because adolescents are often hypermobile.
Hmm.
So, you don't have to send every adolescent to physical therapy, but I do encourage patients to have a physical therapy assessment prior to braces if they do have some sort of history with jaw discomfort and pain.
Now, what would you say is the most frequent age that you see TMD issues?
Goodness. Oh goodness, everything. Um, My youngest that I work on or have worked on is 11. The oldest that I've worked on is 84. No, I had a 90-year-old patient, 90-year-old
There you
patient.
go.
So it's the gamut. The average would
Yeah.
probably be somewhere between 40, 35, and 60. That's going to be my average patient. Demographically speaking, if we're just looking at what type of person is the strongest candidate for TMJD, it's going to be females. It's going to be females
I was
between,
just going to
yep.
ask you, do you see more in females?
Oh, yeah.
Because that's what we see as well and what we
Mhm.
know. But just go ahead, yeah.
Well, and it's just so true. And this is what I like to tell my patients. It's not because, we're just way too stressed, which we are, but I like to say it's because we wear so many hats. There are so many women out there that are career women, that are moms, that are wives, whatever it may be, you wear so many hats that at the end of the day, we are prone to clenching and bruxism. Also, just because we are female, we tend to be more lax. There's a lot more laxity within our ligaments than there is in the male anatomy. And so, therefore, sometimes our joints have a little bit more wiggle room than others. And when that happens, our body sends a signal to our brain to say, hey, wait a minute, what's going on? Pressure signals, just a fun fact, pressure signals always travel faster than pain signals. So if I were to burn my thumb on the stove,
Mhm.
what I usually do is I'll shake it out, maybe say a few four-letter words, and then squeeze my thumb, right? And so the reason I do that is because the nerve fiber that's going to travel to my brain is so much faster than the pain.
Mhm.
So if we have anything degenerative, if we have anything irritable in the joint itself, if we're just not stable in the joint itself, we actually will clench to create a normal sense of self. And then it becomes habitual. So it's going to be also the well-educated female, just how demographics have panned out. Also, it's going to be maybe a female that has some other comorbidity, such as anxiety, depression, things of that nature. And I'll say this, it's kind of funny to me. I don't know why, but a lot of SSRIs,
Okay.
a side effect. So your Prozac, your Lexapro, I can't even think of others, but things of
I
that
know. I was.
nature, right? A side effect is going to be increased clenching and bruxism, which
Mhm.
is funny because you're trying to calm yourself down and then you're doing something that actually increases stress in the jaw. But it changes the serotonin and dopamine balance within the brain, and so that is often something patients are not aware of.
Now, I know we're kind of talking about just generalized information there, and I think one kind of more focused on maybe the dental side and maybe what dentists can do as well. But what is your thoughts on splints? And do you make splints? Do you give things information back to the dentist? What are your thoughts there?
I'm a huge fan of splints. And this is one of the things that I go back to that first question you asked me, what differentiates us between other PT offices. It is part of our um, job. It is part of what we do to send a splint prescription. So we are very well educated on the different types of splints. Now, with that being said, I know there are neuromuscular dentists out there. I know that there are sort of more hard tissue occlusion based dentists out there. I call it sort of the Dawson Spears panky dentist, versus LVI, neuromuscular dentistry. I think one thing everybody can agree on is that the muscles do affect the bite. And so we are very much a fan of once we get them to a correct spot, once we get them to what I call a tolerable spot, you can
Mhm.
open and close repetitiously, and your range of motion is reproducible, repeatable, right? You tell me you do not have pain during certain activities. You haven't had headaches. You haven't had, noises in the joint. That's when we say, okay, I think we're at a pretty stable spot. Now I want you to go into a splint. And the type of splint that we are usually going to prescribe is either going to be a flat plane splint. We are a fan of hard acrylic splints,
Hmm.
just because, you know, when it comes to softer splints, if you, yes, it will protect the teeth and it will protect the enamel and it will protect the tangential forces that go and try to hit the molars, or the anterior teeth. However, if there is some give in the splint itself, it actually can perpetuate a
Yeah.
reflex that we have to clench more.
Yeah, I mean, I agree with you. I like the hard splints as well. I don't really
Yeah,
use too much of the
yeah,
softer or the whatever they call them, the hard soft, the
yeah.
dual
It's yeah,
combination.
something. Yeah. So what we do is we'll send a script over. We check for five. One of the things that we do is we do just a quick scan to see, is there any sort of gum irritation? Are there any sort of abfractions, attrition, recession? Just to clarify that yes, we do believe this patient is a clincher or a bruxer. Um, and then from there, depending on if they're chronic in nature or depending on if they have degeneration in their joint itself, which we often will verify through CT, CBCT imaging, then we will say, okay, flat plane, hard acrylic, full arch, or we're a big fan of anterior guided splints, AGSs.
Hmm.
We do anterior deprogrammers as well. Now, when I say that, we do not make splints because that is not in our wheelhouse. We don't work with the teeth. So what we do is we say, hey, I think this is most optimal for this patient's musculoskeletal behavior pattern, right? And so then I send that splint. This is why that interdisciplinary relationship is so awesome, because this isn't just, oh, you need to go see this person, right? And then you never see him again. No, no,
Hmm.
this is a back and forth. This is an active relationship. Most of the time when I am working with my patients and my associates are working with their patients, we are calling our dentist. We are texting our dentist or our specialist, right? To say, hey, how do you think they're doing? Many times the splint has to be adjusted because all of a sudden their bite is no longer what it used to be. And so we are big fans of that. Somewhere around the fifth week of treatment, we send them back to the orthodontist or back to their practitioner with a
Hmm.
referral to say, hey, we're not done with therapy, but let's start getting the splint ready. Because
I mean, that's really good to know because we definitely have some patients that come in, especially, and I've had a few in my office, and then see some just online and hearing from other friends and things like that in the field. But a lot of people, I've heard splints aren't good, and some I guess have maybe mentioned to them, we don't like to put you in splints because it causes more problems. And I'm always thinking, well, I feel like how I corrected some issues, so I'm kind of different, I guess, in that sense. But I guess
I agree
it's
with
good to
you.
hear that, the way that we were taught and kind
Yes.
of continue to learn and things like that is still kind of the, I think, best option.
Well, and the thing is, if a splint, for someone that wants to come with that statement, right? And you say, well, it messed things up, it made things worse. There's so much information not being said in that statement.
Hmm.
Why? Did it not fit correctly? Was it the wrong splint? Did their bite adjust in one way or another and the splint was never adjusted? There's a lot of reasons
Exactly.
behind why the splint wasn't correct. But in all actuality, there is no way, we have not yet found out, medically, in any capacity, how we can go into the midbrain, right, and stimulate it so that we can turn off the clenching
Right,
light
right.
switch. So you're going to clench. And when you put a
Yeah.
splint in your mouth, you're probably going to clench a little bit more. But
Hmm.
because it's hard, because it's acrylic, right? It caps the amount of force that you clench down with. So you're actually not creating any excessive damage. And one of the things that you really want to protect as a dentist, in and of yourself is the PDLs. You don't want to create an environment for, a PDL sprain or strain, right? Which decreases the integrity of the tooth and the gum.
Well, that's good because I know I had, it was perfect timing to speak with you because I had a few patients even this past week or 2 weeks ago that, were really intrigued. I kind of had mentioned that I was,
Yeah.
going to be speaking with you and learning a little bit more as well. And I was
Yeah.
like, let's get another expert and we'll get some more information and you can hear it from multiple sources instead of just one
Absolutely.
and make you feel comfortable. But I would say, that's really good to know, especially for the dentist. I think
Hmm.
with any dental field or any field, and maybe some get a little worried in the sense of referring to someone that may start to take over and like you said, never see their patient again. But I think
Right.
it's great for them to hear that it's mutual, a
Hmm.
patient, and it's a multidisciplinary work together, and we're all here to achieve the same goal. So I think that's
100%.
good to hear.
Absolutely. Absolutely. I think that
Well,
that's the
let's
only way. Yep.
yeah, exactly. I would agree with you, and sorry for cutting you off there,
Yeah.
but I would say, let's we talked obviously a little bit about, I kind of focused a little more on orthodontic and treatment and things like that with you. But what are types of treatment modalities you use,
Hmm.
needling, except, and other things
Hmm.
in that nature as well?
Absolutely. So it depends on what the patient needs. It's not a one and done. I do not have a blueprint. My associates do not have a blueprint. Being that, the patient comes in, this is what we do, boom, 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 and then you're good. It totally depends. Now, of those options, what we can do is yes, dry needling. Dry needling can be something that is done for trigger point release. It can also be done for what we call neuromuscular reeducation. So sometimes we may go in and want to dry needle the muscle and put a little bit of stimulation to it to pulse that muscle. And that often goes hand in hand with muscle re-education if it has become inhibited for whatever particular reason. Something else that we do is laser therapy. This is something that's really big in our clinic. We have lasers in all of our clinics, and they are all grade 4 medical lasers. So they're extremely concentrated, the beam itself. It is not to a superficial level. It actually goes all the way through to the bone. However, there is constant movement there, and it is at a certain wattage. We can do intraoral laser, or we can do external laser, and it is to the soft tissue. So that is something that we do. Our laser is a tri-wave diode, meaning that the wavelengths, the three wavelengths that are associated with that beam, are going to be for tissue regenesis, right? Collagen regeneration, are going to be for pain reduction and inflammation reduction. So that's something that we also do. We will do external stimulation just cutaneously. We
Okay.
use something called an H wave, but we may put that on them and then have them do certain exercises, and just to help promote a certain behavior pattern that we're looking for. We will do some Grafton scraping if we need to, kind of, around the masseter into the SCM and the scalenes. But for the most part, those are the three modalities that we use the most, or the four modalities we use the most.
Well, that's good to know. I think what we have all learned, at least today, is I think you bring a wonderful expertise to the community, and I think probably with COVID, I feel like, and wearing masks, a lot of people started to
Mm-hmm.
have more symptoms and TMD and
Oh.
TMJ. I don't know if it's, the pressure of the mask or people
Mm-hmm.
playing with the mask with their mouth, because I did, moving it up and down, and you just
All the
started to
above,
use your
right?
facial muscles more. And I think it probably brought a lot of new patients to you because
It
it
did.
was definitely heard, and even people who didn't have any issues and didn't have issues and still don't have
Mm-hmm.
issues, it still kind of made your jaw sore because you have even just a little bit of pressure pulling.
The mask thing, and I kid with my dad and my brother, and I'm like, the rest of the world wasn't ready for what you guys do every day, wear a mask, and
Yeah,
it
yeah.
just because with dentistry. But the thing about a mask, and especially those N95 masks, and this is going to be in direct opposition of the health reasons you should wear it. So just from a jaw perspective, right? it creates a situation where we become mouth breathers. Oftentimes, when we have the mask on, we no longer just breathe through our nose, whether it be something that was a claustrophobia type issue, or just kind of feeling like you're not getting a good breath. Also, we're having to speak louder because many times you feel like you can't hear yourself or someone else with a mask on. And so, what this is going to do is change the position of the mandible, like we talked about before. So, with a forward head posture, our mandible is going to move posterior and superior, and it does the same thing with a mask. And so, in all reality, yes, it's going to create muscle soreness, but because they're holding their mouth different.
Right.
It completely changes the game for everybody, and you don't know it. It's just like if you go outside. My husband right now is building a playhouse for our girls, right? You go outside and you build something and you think, "Oh, I'm fine. I don't have any pain." And then 5 days later, "Oh my goodness, every bone muscle in his body hurts." Right? And it's the same thing with the mask. You wear it and you think, "Oh, I don't have any issues." And then all of a sudden, because of habitual behavior patterns that you've changed because of the way that your body has adapted to the mask, now we have problems.
I think it's good to hear, sometimes things you wonder and you say, yeah, it probably does have it, but I have nothing to base it off of. And now you get a little bit of more information. So it
Right,
makes
right, right.
you feel better that what you say, sometimes it's not always wrong. So
But I will say now we don't say stop wearing masks. With
no,
all of that
right,
being said, right? So what we do is we re-educate so that you can wear the mask and not have jaw pain.
right.
That's
And exactly. Definitely still have to do your part and
right, right.
protect. Well, I mean, I think I had a wonderful time with you. Is there anything
Thank you.
else that you think that we should be aware of, and that we maybe didn't touch on?
I think we touched on a lot of good things, and I
Yeah.
think the biggest thing for me is just letting it's just the awareness, right? And that's why I'm placing practices in different areas of the triangle, because at the end of the day, this is something that so many patients deal with, dentists themselves, right? You yourself, myself. It's something that a lot of people I feel like have, which is jaw discomfort. Or dysfunction, and there just hasn't been a lot of awareness. And so I love to allow and provide a conservative way for patients to move forward.
Well, that's great. We were so lucky that you decided to come on and talk with us and
Thank you so much
enjoy
for
and have a
having
fun
me.
time with the podcast. No, it was a pleasure to have you, and I'd love to have you back if
Yeah,
always would like to. So, just for everyone else out there, this is Dr. Miller with Miller Concierge TMJ Physical Therapy. I think she said she has locations right now in Durham, Raleigh, and Fuquay. Was that the
correct.
yes? And
Correct.
so, and your dentist, if you are at a dental office and they're not aware of who she is, mention it to your dentist and
Yeah.
allow, spread the word, because every dentist has had patients and will always have patients with TMJ, TMD issues. And sometimes we can struggle with getting correction and need assistance with someone who has good expertise and knowledge in that field. So we're so lucky to have you on here, Dr. Miller. Um,
Thank you so much.
Enjoy the rest of your day. Hopefully the weather starts to warm up, at least no
I
rain,
know.
but now we
I
get cold
know.
weather, but it's coming. The warmth is coming.
The warmth is coming, but I think some of us are enjoying actual fall at the moment,
Yeah, this
So
is definitely
just
fall.
don't get too much colder. Just don't get too much colder.
Exactly. Well, it was a pleasure having you on. Have a good rest of your day.
I hope you do too.